I think it goes back to looking at the legislative intent, which in today's conversations often get cut into two pieces. The legislative intent says to help the safety net stretch scarce federal resources. A lot of us think about $5 of a copay being not a big deal.
Yep.
That is a big deal to someone who is trying to put food on the table.
Yep.
But when I worked inside of FQHC, I would see the impact of 340B every day. Cover medications, the cost of medication going down the pharmacy counter. Well, I think the current environment, what the largest challenge would be is contract pharmacies at this point. Contract pharmacies and especially with smaller entities who are trying to really do that mission-focused work are paying exuberant fees to large for-profit pharmacy chains. Absolutely. When Canvas started 30 years ago, it was one man who went to Congress and advocated to make sure that the response to the AIDS epidemic was measurable, was proportional to the size of the actual epidemic.
Welcome to 340B Pulse, a NorthArc Health podcast powered by Purologics. I'm Muhammad Atif, your host. I'm CTO and President at Purologics and NorthArc Health. For nearly 2 decades, we have been building healthcare system infrastructure, data platform, and compliance-heavy environments where precision really matters. Over the time, that work eventually brought us closer to the financial and operational pressures shaping pharmacy and 340B today. And that's really why this podcast exists. 340B Pulse is about thoughtful operator-level conversations, not noise, not headlines, but real execution discussions like how this program actually functions day to day. I'm joined today by my co-host Hassan, who leads product and infrastructure initiative across 340B and pharmacy workflows ecosystems.
Thanks, Atif. A little about myself. I'm a senior consultant at NorthArc Health. I spend most of my time working alongside covered entities, helping them navigate the 340B program. Really excited to be the co-host today and looking forward to the episode where we explore how 340B savings translate into real patient impact.
Absolutely. And as you mentioned about the topic, so we are going to discuss turning 340B saving into mission impact. So we shall be exploring how savings generated through the 340B drug processing program are ultimately intended to serve one purpose: improving access, dignity, and care for vulnerable, low-income, uninsured, and under-resourced patients. And its core 340B is just not a pricing program. It is a patient access program. And today's conversation is going to focus on what that actually look like in practice.
And to help us unpack this, we are joined by Kalvin Pugh. Kalvin is a 340B policy director with deep experience in community engagement, covered entity operations, and policy frameworks shaping how 340B programs function today. He's known for bringing a human lens to a space that can sometimes get lost in financial mechanics, keeping patients and communities at the center of every conversation. Kalvin, a very warm welcome to 340B Pulse. Really glad to have you with us today.
Thank you so much for having me.
So Kalvin, before we dive in, it would be great if you can tell us about your journey and how did you get started and overall your experience so far.
Well, I think like most people who get into 340B, I kind of fell into it. But I always tell folks that I'm the living, breathing example of what it looks like when 340B operates the way it's intended. I was diagnosed with HIV in 2016, and through the state's ADAP program, which is mostly funded by rebates, through 340B, I was able to access medication that not only saved my life, but that has resulted in me being incredibly healthy. And now I spend a lot of my time advocating that this program works the way it was intended statutorily, through meetings with lawmakers and in testifying in Congress and across State House across the country. So I came to Cannes 2 years ago because someone needed to have a full focus on this very vital patient access program.
Very nice. So let's start at the core of what we want to explore today. And thank you so much for that background, because that really ties into our conversation today. From your perspective, Kalvin, as a 340B policy director, how do you personally define the term turning savings into mission impact? How do you define it in today's 340B environment?
I think it goes back to looking at the legislative intent, which in today's conversations often get cut into two pieces. The legislative intent says to help the safety net stretch scarce federal resources. And that's usually where a lot of entities stop when they're in a state house and we're talking to the federal government about this program. But the intent continues on to reach more eligible patients and provide more comprehensive services. What that looks like in today's landscape is the FQHC that is down the street from me here buys dental vans to make sure that folks who don't have access to dental care, or they use it to cover medication, what it looks like in real life and what it should look like is lower prices at the pharmacy counter or greater access to healthcare for communities who otherwise just wouldn't have it.
Right. Legislative intent is really quite important, yes. And when you think about covered entities participating in the 340B drug pricing program, where do you see the biggest gap between savings generated and impact actually demonstrated?
Well, I think there's a lot of reporting on where we're seeing the lack of that, where that gap is happening, especially in large health systems, who have unfortunately decided to utilize some loopholes in legislative intent and some unclarity from HRSA about how their program savings should be used. I think we run into the problem of a lack of transparency in this program for large health systems, whereas FQHCs or the Ryan White AIDS drug assistance programs, they're required to report everything to HRSA, how they operate. And not everyone's doing that. And the gap is where, the reality is if large health systems are doing exactly what they say they are doing so many patient programs, prove it.
Mm-hmm. Mm-hmm. And what do you think separates a covered entity that creates visible patient impact from a covered entity that is struggling to demonstrate exactly that?
I don't know that there's a struggle of demonstrating it. I think there's a lack of willingness to demonstrate it. The recent reports of Super Bowl commercials being bought or football teams being paid for, or even in a very egregious report out of the Los Angeles Times that a covered entity used their 340B savings to buy a slum and people died. The separation is, I think you see it in the real world and on the patient level, is what is the community health outcomes? What is the health department measuring in that city or in that area? We need to know those things so we make sure that this program is aligned the way it was intended to be utilized.
Yeah, visibility is quite important. Do you think the challenge today is more about lack of impact or lack of visibility from drawing from what you've said?
I think we have to. I think there are two things that can be true at once. I think there is a lack of impact when we see large health systems buy up smaller entities and consolidate care. That's a lack of impact when you're taking care out of a community that needs it. But there's a lack of visibility on that impact. And we can gain some insight from tax documents, but there is a need for greater transparency in this program so we understand that it is working the way it was intended.
Awesome. So I want to bring this down to a patient level, Kalvin, for a moment, because that's ultimately what this is all about. You mentioned that at the start of this conversation that you have been through this journey. You are diagnosed with HIV and went through all this. So from your experience in community engagement work, what do patients actually feel or notice when 340B savings are working well inside a system?
I think patients who struggle to pay their medical bills or have a lack of insurance or underinsured, I think that patients feel that at the pharmacy counter when they have to pay copay. Because a lot of us think about $5 of a copay being not a big deal.
Yep.
That is a big deal to someone who is trying to put food on the table.
Yep.
But when I worked inside of FQHC, I would see the impact of 340B every day. Medications, the cost of medication going down to the pharmacy counter, or creating more access to patients who just wouldn't have it.
Got it. And I totally agree on that. So I think sometimes it feels like the policy debate can overshadow that patient reality entirely. So Kalvin, do you think the 340B debate sometimes becomes so focused on policies and financial mechanism that people lose the sight of the patient program was originally meant to serve? That what was the original purpose behind that?
I think it does get lost. I think that's lost sight often, especially when we look at hearings that are happening in Congress. There has yet to be a patient impact or any kind of measurable patient discussion on how this program works. And so that we've lost the plot here. When the reality is that patients should be benefiting from a program that is now being used to profiteer by large systems and for-profit companies. We've lost sight, and I think it's time for Congress to act truly to make sure that we have clarity on how this program should work.
So you bring out very important point that we have these big players that are in the game. Due to them, we have lost the actual value of this program. So according to your experience, what are the biggest challenges that covered entities are facing when they try to translate 340B saving into measurable mission impact?
Well, I think the current environment, what the largest challenge would be, is contract pharmacies at this point. Contract pharmacies and especially with smaller entities who are trying to really do that mission focused work, are paying exuberant fees to large for-profit pharmacy chains, and that value is being extracted from this program. We can talk all day about how the reports of what big things have been done, but that small amount that increases 20% over year, a small entity can't cover an increased 20% on top of the rising cost of everything else in this country. And if we really want to hone down, we want to talk about contract sufficiency. Do these small entities have enough leverage? No, they don't. Do large hospital systems? They do. And yesterday we saw in the news that several large hospital systems are going to take on one of the chain pharmacies, and they are filing a lawsuit for the extreme amount of fees that are being extracted from this program that could be used to increase patient care.
Got it. So talking about the operational and reporting challenges, let's stay on the operational side for a moment, because I know this is where a lot of organizations feel the pressure. So how do operational constraints like data limitation or contract pharmacy structure or reporting complexities, they can affect an organization's ability to demonstrate the impact?
I mean, you can't improve what you don't know the number of. So if you don't have a good data visualization, the concern for me, for any covered entity, is that if you are not keeping track of the data, then how do you know what you're bringing in and out? And that's a concern, especially when you come to things like HRSA audits. Well, HRSA's limitation in auditing entities is obscene. However, if they're not measuring those and they don't want to be willing to demonstrate that impact, they're probably not ready for an audit. Those HRSA audits, I have lived through one. They are not there. That's no joke.
So according to you, having the proper data files and reporting and passing those HRSA audit, it can bring a lot of visibility, right?
Absolutely. Yeah. And I think unless someone's trying to hide something, I think that would bring absolute visibility to demonstrate the impact of how that entity is using this program.
Got it. And Kalvin, what are your thoughts about the rebate program that went on the pause? And 2025 was all about rebate program. Everyone was running to make sure that they are fully compliant to that.
I think the pilot program was a mistake. If we want to talk about a pilot of a rebate model for 340B, we don't have to look any further than state AIDS drug assistance programs who have run on a rebate model for the entire time they have been named the only payer grantee in the 340B legislation. They have done it on a rebate model the entire time. If each state can handle that, so can everyone else. And I think a rebate model is the first step in making sure that this program is better aligned with its legislative intent.
And do you think it will be resumed, or is it going to be on hold for a while?
I think we'll see it resume. I think there are some mechanics happening inside that department of the government that need working out, but I think we'll see that soon. I also believe that at some point in the near future, we'll see actual legislation be introduced other than what has already been introduced. The group in Congress have been actively working on what that next step looks like.
But Kalvin, don't you think it will increase a lot of clerical and operational work on the covered entities, and especially the small covered entities who are already having less staff and less budget?
I mean, yeah, theoretically, yes, but in the actual rebate, as it were, that's those costs are being covered by the pharmaceutical industry. So that concern is kind of moot at this point.
Got it. So where do you see the strongest alignment and the biggest disconnect between the 340B policy goals and what happens on the ground in communities?
I see that the strongest alignment is among patient groups. When we started doing this work, when I joined an advisory committee on 340B it's about 3 years ago, and there was a lack of patient engagement on 340B. There was a lack of patient awareness on 340B. People had no idea, and still to this day, I say 340B and people's eyes glaze over. But currently, I think the strongest alignment is patient groups, especially your rare disease groups, your cancer groups. Those folks, they're aligned with the work that is being done. And I think the biggest disconnect is the actual impact being demonstrated by a lack of transparency by large health systems and the for-profit companies that have aligned with them.
Mm-hmm. And there's a real tension between the data and narrative, between financial story and human stories. How important do you think patient stories and real-world community outcomes are when exploring the value of 340B, especially compared to purely financial reporting?
I think again, two things can be true at once. I think we should have real patient impact. In fact, there is actually a new report coming out about real-world patient impact. We've also released a few patient policy briefs that that I'll talk about the state work being done, and happy to share those with folks at another time. But that's vital to knowing that this program is operating the way it was intended to serve those people. And I think that we have to do a better job of telling that narrative of the difference between a mom deciding medication for her children and food, because that program is not being used the way it's.
Mm-hmm. And that leads into a question about the role of leadership in creating more consistency here. What role should policy leaders play in helping standardize or clarify what mission impact should mean across different types of covered entities?
Well, I think lawmakers have all of the. I think the federal lawmakers have a key role in standardizing this program to make sure that it aligns the way it is intended to work. I think we have to go beyond what mission impact looks like. I think we need stronger definitions of what patient benefit is. That hasn't been updated since the 60s. And I think we have a long way in going. When this program was created, the world has changed, and we need to bring that program, and policymakers have every key role in doing that.
Mm-hmm. And Kalvin, let me ask you this, looking ahead, if you had to design an ideal system today, how would it connect 340B savings to real outcomes for patients and communities?
An ideal system. I mean, I think an ideal system would be transparency that is mirrored of state aid drug assistance programs and FQHCs and what they're required to do. I think showing that in a financial or in an actual document of this is how many patients were served, this is how much money that we use, this is how much we paid in fees. I think those things are key to understanding how we can make this program work for a lot more people.
Great. So, Kalvin, I was just looking at CAN. So tell us a bit about CAN, what you guys are doing. I see that you guys have a lot of research and educational initiatives and then public policy development. So for the audience, if you can give up what value you guys are adding in this space, that would be awesome.
Absolutely. When CAN was started 30 years ago, it was one man who went to Congress and advocated to make sure that the response to the AIDS epidemic was measurable, was proportional to the size of the actual epidemic. Worked with Congress over the years to increase funding for HIV, substance use, and tuberculosis. CAN has evolved over the last year, 2 years, into being a patient-centered policy institute. We involve ourselves in most things to do with patient access or payment or repayment, or patient drug affordability on top of that. We work in a myriad of different spaces while keeping in mind that the mission of this organization originally was HIV. which is still something that we really do still have to advocate for across the country. You would think after 45 years of this epidemic that we wouldn't have to do that any longer, but we still do. So CAN's focus is patient access, patient affordability, and we work across both those subject lines in both state houses and in the federal government.
Awesome. That seems like a great initiative, and I see you guys working as a non-profit, right?
Yes, sir.
So tell me, are you guys using any kind of technology? And nowadays you may be hearing a lot about AI, any kind of system or any kind of innovation to bring this awareness among the people?
We work with a lot of partners across the country, but currently, I mean, obviously most of us use AI for some kind of data assistant or finding things that we need quickly. As far as other technology, not anything past a standard Google platform where we work.
Got it, right. So Kalvin, let's switch gear a bit. So we will have quick rapid fire type of question, and you can just answer in yes or no. Let me know when you're ready.
Go right ahead.
All right. So here we go. So do you think most organizations can clearly track how 340B savings are used today?
Yes.
Do 340B saving consistently translate into visible patient level benefits?
No.
Is mission impact currently defined too loosely in 340B space?
Yes.
Are covered entities under pressure to better justify their use of 340B savings?
Yes.
Is there currently a gap between 340B policy intent and real world outcomes?
1,000% yes.
Will measuring mission impact become more important in future 340B policy discussions?
Yes.
All right, very clear. Thank you, Kalvin. So, Kalvin, for someone who is starting in the 340B space, whether it is like a manufacturer or whether it is like a pharmacy or contract pharmacy or cover entity, do you have any advice for them how they can work cohesively to make this program really impactable, which is really giving the care to the patient who are eligible for this one? Any advice, any thoughts you wanted to share?
I think it goes back to the human aspect of we have to remember that this program was intended to expand patient access and provide more comprehensive services. While we can certainly belabor what patient benefit looks like, I think if we all show up in this space with the intention of we are going to provide more access and provide more eligible services, I think that is the place to start.
Thank you, Kalvin, and I totally agree on that. So before we wrap it up, like if anyone who is listening this and wanted to reach out to you or connect with you or wanted to learn more about CAN, so what is the best way to connect with you?
You can reach out to me by email, which is Kalvin, KALVIN, at TIICANN.org. Or I can be found on Twitter at Kalvin_Pugh, P-U-G-H.
We really appreciate you joining us today, Kalvin, and sharing both the financial and operational realities shaping pharmacy strategy today. And to everyone listening, thank you for joining us on 340B Pulse. We'll see you next time.
Thank you, Kalvin.
Thank you so much.